Welcome, everyone, and thank you for joining the Children's Hospital Colorado Genetics Virtual Education Series. Today's topic is Ehlers-Danlos Syndromes, more than just skin and joints. Our virtual education series is designed to be interactive, so we strongly encourage audience questions. And since cameras and microphones will remain muted throughout the session, please submit your questions via our group chat feature. A handout to include instructions on how to access group chat was sent to all registered participants. Our speaker will be happy to respond to audience questions during our Q&A at the end of the presentation. Please allow me to now introduce our speaker for today's session. Dr. Ellen Roy Elias, Professor, Pediatrics and Genetics, University of Colorado School of Medicine, and Director, Special Care Clinic at Children's Hospital Colorado. Thank you all again for joining us today. Now let's begin.
Thank you so much. Hello, everybody. It's really a pleasure to be here, and I just wish I could see you all in person. So I'm going to be talking today about a syndrome that is near and dear to my heart, Ehlers-Danlos. I have no conflicts of interest. I did want to thank and acknowledge my dear friend, Claire Francomano. Dr. Francomano is one of the premier geneticists in the country and known throughout the world regarding her expertise in caring for patients with EDS. And in a very bizarre way, Claire and I were best friends over 60 years ago when we were in kindergarten, and we both grew up to be geneticists interested in patients with Ehlers-Danlos. I wanted to acknowledge that Claire and I gave a joint talk at the recent American Academy of Pediatrics clinical meeting. And some of the slides that I'll be showing you were pretty slides that Dr. Francomano has made and allowed me to borrow. So of the EDS syndromes, there are 14 currently known types that have really quite a wide range of presentations. We know the genes that cause 13 of the 14 types, and these are genes that affect structural proteins in the connective tissue and the enzymes involved in processing these proteins. But the most common form of Ehlers-Danlos, the hypermobile type, seen in about 1 in 5,000 patients, is the type that we do not know the underlying causative genes. And in my mind, I'm sure there's more than one. So this is just a list of the genes that we do know, which cause Ehlers-Danlos. The most common forms that we see for which we know the genes are the classical type caused by mutations in collagen 5A1 and collagen 5A2, and the vascular type caused by changes in collagen 3A1. And then these other types of Ehlers-Danlos are mostly quite rare, although we have seen them in my practice. I wanted to point out for you this gene, tenascin XB, which has been reported to cause an autosomal recessive disorder, unlike these more common types up here, which are dominant disorders. And I just wanted to let you know a little bit more about that particular gene towards the end of my talk. So this is a very pretty slide I borrowed from my friend Claire Francomano just to sort of show you that amongst these 14 types of Ehlers-Danlos, we know many of these genes, but the causative genes of the hypermobile form are still unknown. And this is despite intense research to identify these genes. Another important thing I wanted to mention is that there is significant overlap, as you'll be hearing in a few minutes, between some of these types of Ehlers-Danlos. And I have a number of patients who met the criteria for the hypermobile form. And then when I was able to do actually molecular testing, were found to have changes in collagen 5A2 and So I just feel in my mind there's a huge overlap between the mild classical form and the hypermobile form. So patients with Ehlers-Danlos have symptoms which involve not just their skin and not just their joints, but actually all your organs throughout your body. Because collagens and these connective tissue proteins are really ubiquitous and are found throughout your body. And so we can see symptoms and features in patients with EDS involving all of these different places. And that's one of the major challenges actually to caring for these patients, because they can present with very significant medical symptoms involving other organs and systems. So I wanted to talk a little bit about those in detail, and first mention what these symptoms can look like in adults. In the adult literature and in adult Ehlers-Danlos clinics around the country and through Europe, most of what we know about these other symptoms seen in patients with EDS is from adult patients, and the literature is mostly based on adults as well. So for patients, the musculoskeletal system is almost universally involved, and you can see pain and discomfort in patients because of this. Their joints are very hypermobile. They can sublux, they can dislocate, and that can lead to chronic pain over time and some functional issues with how their joints work. The other two major symptoms that I see most commonly in addition to joints and skin are the heart, and symptoms can commonly involve postural orthostatic tachycardia syndrome, or POTS, mitral valve prolapse. A subset of patients can have aortic root dilatation, and it's fairly common to see venous insufficiency, particularly in the lower extremities in this group of patients. Wearing things like support hose can be very helpful, and some of these patients need to be followed quite closely by a cardiologist. The GI symptoms are also incredibly common in this patient population. Many of them have reflux, esophageal reflux disease. I'd say a large percentage of my patients have inflammatory bowel disease of various kinds. Abdominal pain and bloating and constipation are very, very common. And food intolerance is also pretty common. A subset of patients have celiac disease, which can cause both diarrhea and constipation. Neurologic issues are becoming more prominent. We're learning more about them as time goes on. So I'd say that headaches is incredibly common in my patients, in well more than half. And then a subset of patients can have neuropathic pain that can be amenable to certain medications that neurologists are comfortable using, like Tegretol. Autonomic dysfunction is more than just POTS, and so you can see people with abnormalities of their sympathetic nervous system. They can have abnormalities of flushing and temperature instability. A subset of patients have small fiber neuropathy, which is predominantly diagnosed doing a biopsy of the skin, in which you can see neural fibers. And then some patients have venous insufficiency within the brain, which is very difficult to manage and treat. Not everybody, but a subset of patients have a Chiari-1 malformation, where part of the brainstem sinks through the foramen magnum and can sit in the cervical area and cause symptoms that include headache and compression of cranial nerves and upper cervical nerves. And one of the issues that is really somewhat controversial is that of craniocervical instability. And there's a group of physicians, including neurosurgeons and neurologists, who really believe that this is a major concern for these patients. And then another group, including some of our neurosurgeons here in Colorado, who think that this is way overrated, and how you need to diagnose it, including certain special kinds of MRIs and so on, is not well documented in literature, even in neurosurgical literature, and is a topic that really needs to be better studied. In adults, especially females, there can be a lot of issues that involve bladder function and pelvic floor dysfunction and pain. And so often a team that includes both GYN physicians as well as urologists are necessary for helping families navigate this particular issue. So children, I'm a pediatrician, and I am much more comfortable with pediatric patients than with adult patients. In the clinic that we've started here at Children's, that I'll tell you a lot more about in a bit, we see patients up to age 30. But I have most of my experience with connective tissue disorders in pediatric patients, and they present differently than adults do. And so what I wanted to do in this next part of the talk is talk a little bit about how children are different, and how some of the issues that we deal with in pediatric patients are very similar to adults, but can be quite unique in younger children. And the areas that I sort of highlighted in red are particular problems that may be more apparent in younger patients with EDS than in adults. So to take a deeper dive into this area of how children are different, children can have cardiac issues, including POTS and aortic root dilatation, but children don't pop out of the uterus and go running down the pasture. There's a lot of sort of developmental skills that develop during early and middle childhood, particularly involving development in what I call the motor sphere. So it's learning how to sit, stand, walk, run, do all of those motor things. And very often patients with EDS have developmental lag in these areas related to how their joints are functioning. The neurologic issues, including the headaches, are common to see in pediatric patients as well. Immunologic issues, including mast cell activation, we'll talk about that in more detail in a moment. We can see and do see in pediatric patients. And so working with immunology and allergy is really critical in this population. And then the mental health issues, which are present in adults, start in pediatric age patients, particularly the teenagers, and can really affect functionality in these patients, as can their chronic pain. So when I'm trying to assess joint hypermobility in young children and pediatric patients, I think it's important to know that not all patients with joint hypermobility have EDS. Generalized joint hypermobility is actually not that rare. It can be seen in 10 to 20% of healthy individuals, and it can be seen in pediatric patients with a variety of underlying diagnoses with quite a broad spectrum of severity. So young children who have hypotonia, low muscle tone, from a variety of underlying causes, often display joint hypermobility at the same time as their hypotonia. And so it can be really tricky when I'm seeing a small child, a young child, who's presenting with developmental delay, feeding issues, failure to thrive, birth defects, other dysmorphic features. In my mind, the hypermobile joints that I'm seeing in a patient with that constellation of findings is much more likely to have an underlying genetic cause that's not Ehlers-Danlos, especially if that patient has autism. So in the old days, I was talking with Erica a little bit before starting this program. I've been a physician now for 40 years. And in the old days, before we realized what caused Fragile X syndrome, people thought that patients with Fragile X actually had a connective tissue disorder because they were so bendy. And so I think it's really important to note that if you're seeing this constellation of other issues, intellectual disability, and especially autism, that it's important to go looking for other causes. And Fragile X is one of the more common ones in that category. So it's common to see joint hypermobility in patients who have neuromuscular disorders, again, related to the hypotonia often, in kids with autoimmune disorders, such as arthritis, and then some skeletal dysplasias, such as osteogenesis imperfecta and Larsen syndrome, can have joint hypermobility too. And in fact, one of the genes, the most common gene that causes OI, collagen 1, also can cause a dominant form of EDS. And so it's really important to try to get as detailed a medical history as you can, an excellent pedigree and family history, and a really, really good, careful physical exam when you're trying to evaluate pediatric patients with hypermobility, because often the underlying diagnosis is clear and it's not EDS. So here's a pretty picture of the Beighton score, and I think any of us who have ever evaluated a patient to rule out Ehlers-Danlos, the Hypermobility Forum knows this scale pretty well. The most you can get is a 9, and you get points each for bending back your pinky, having your thumb touch your forearm, how hypermobile and hyperextending you can do in your elbows and your knees, and then being able to touch the ground with flat hands and your knees straight. So one of the things I wanted to mention about the Beighton score is that this is really tricky to do in a very young child. I don't know if you've ever had a 3-year-old you were asking to stand up and touch the ground. It just doesn't happen. And so the Beighton score is it's all we got. It's the only real scale that we have for assessing hypermobility, but it doesn't work really well in young children. It's very hard to do. And the other thing I wanted to say about the Beighton are the joints it does not include. So it doesn't look at your shoulders, it doesn't look at your hips, it doesn't look at your jaw. And so there are many other areas that patients with hypermobile EDS can present with mobility that are not reflected in the Beighton score. And so it's very, very possible to have a patient who clearly is hypermobile when you're looking at large joints, but can have a low Beighton score. So talking about the skin issues for a moment. Because the skin integrity is very dependent on the proteins in the skin, particularly collagen proteins. There are other proteins in your skin that are important for skin integrity. And so it's very common to see in all the different forms of Ehlers-Danlos some skin elasticity where you can pull the skin on the forearm way up, or the skin behind your elbows, or the skin in the neck. The skin on the abdomen is a common place I look at in kids. And how elastic is it? It's common to see wounds that heal, that take a much longer time to heal, and sometimes it's even necessary to go back and put stitches in again. The elasticity is much more prominent with classical EDS with collagen 5 mutations than it is in hypermobile. But again, as I mentioned earlier, sometimes it's really hard to tell the difference between the mild classical form and the hypermobile form. And in hypermobile EDS, you can sometimes see scars that are a little bit widened, just not as prominently as they are with classical EDS. Striae are really common to see in patients with Ehlers-Danlos, as are recurrent hernias. Pediatric patients often have easy bruising and they're just covered head to toe in black and blue marks, and they may bleed more profusely from just minor injuries. That has gotten patients' parents into trouble because people who aren't aware of this will look at a child who's covered with bruises and think that the patient has suffered child abuse. And so it's often helpful to talk to parents and say, hey, this is a common part of this disease, so that they can let people know to not be surprised. And so if you have joint hypermobility, soft skin, and multiple fractures, that may actually suggest that the patient has OI rather than EDS, but having hypermobile EDS is not associated with an increased propensity to fracture. So some patients who've been falsely accused of child abuse because of the bleeding and the bruising, you can say, no, that's EDS. But if the patient has had a lot of fractures, that is not EDS, unless it's a collagen 1 mutation. So I have tried to support my families who have been falsely accused of child abuse, both with OI and EDS. So I wanted to talk about nutritional concerns for a moment, because children, unlike adults, are growing creatures, and they need good nutrition in order to be able to grow from a small size into an adult-sized person. So feeding problems are probably the most common issue that leads to patients presenting to my EDS clinic. And they can include severe constipation, feeding intolerance, symptoms that look like reflux. Multiple food allergies is a common thing to see. And some of these patients actually have failure to thrive and very, very bad weight gain, necessitating caloric supplementation and even feeding tubes sometimes. The severe constipation can lead to a patient sometimes needing cecostomy tubes. And the inability to tolerate certain things in the diet very frequently leads to nutritional deficiency. So low iron, vitamin D, and zinc are the common ones that I screen for. And I just wanted to say that patients that present with very severe constipation, failure to thrive, and have skin that appears really translucent with sort of prominent eyes, these are kids in whom I've made a diagnosis of vascular EDS. And if you're seeing that, especially the translucent skin in a patient with severe GI disease, that's a really important clue. So the nutritional issues are something I deal with every day, multiple times a day in special care clinic. And I'm fortunate to have 5 dietitians in that clinic. I have 2 dietitians at every clinic session. We do a lot of nutritional consultation. We check a lot of labs and supplement those if they're low. And then we often refer for formal allergy testing, especially if there's a strong history of allergy in the family. Eosinophilic esophagitis is something I wanted to mention because it's a very common issue that happens in my patients with EDS. These are kids who have all those common GI problems that I just mentioned, but they don't respond and get better to the typical management that I just mentioned. And these are kids that have lots and lots of food allergies. The association between eosinophilic esophagitis and connective tissue disorders was first reported by the Hopkins group in patients with Loeys-Dietz, a different connective tissue disorder, but it's also associated with hypermobile EDS. And this diagnosis is made by doing biopsies of the GI tract, and you find an increased number of eosinophils on the biopsy specimens, and you can see them throughout the GI tract, the esophagus, the stomach, the duodenum, and the intestine. And patients with this diagnosis require a special diet with elimination of foods they're allergic to, and they're treated with inhaled steroids and special hypoallergenic formula sometimes. And there's a really awesome clinic here at Children's run by Glenn Ferruta, who is an expert in this disease from around the country. And a lot of patients that I've seen with EDS come from the EOE clinic here. This requires special gastroenterology expertise and management. Immunologic issues are common in this patient population, but we do not know that much about this. You can see the routine autoimmune disorders such as hypothyroidism and celiac disease, diabetes in this patient population. We're about to embark, I'm hoping, within the next 6 months on a research study to better understand the autoimmune problems that these patients can see. And then there's this condition called mast cell activation syndrome, where patients look like they're having severe allergic reactions to things, but you do allergy tests and they're not actually positive. Sometimes you can see an elevated tryptase level in some of these patients, but not everybody does. We have 2 awesome allergy immunology specialists who work with our EDS team to manage this particular issue, which requires special medications to help. And I wanted to make a really important point. There has been some stuff on social media and so on that giving the HPV vaccine to teenagers exacerbates or can even cause their worsening symptoms in hypermobile EDS. There's no scientific basis for this. It's a lot of what comes out of the back end of a male cow, and we feel really strongly that patients with EDS should receive their HPV vaccine along the usual routine. Mast cell can be seen along with the EOE can also affect the GI and the urologic tracts. So patients can have symptoms that look like recurrent urinary tract infections, but it's really inflammation of their bladder. And so this requires special medications in order to look for mast cells on biopsies, which we do concurrently with looking for eosinophils. There's a special stain for mast cells on biopsy that we're now more routinely doing. And the medications that can help the most are Singulair, Montelukast, and Cromolyn. So cardiac disease, we often do echoes in these patients to look for aortic root dilatation. The recommendation for that has become less robust very recently, but we definitely do this in patients with vascular EDS. And then POTS symptoms are just very, very common. Usually it's you stand up and your heart rate goes up, your blood pressure goes down, and boom, you faint on the floor. This is a problem we see generally in post-pubertal patients. And the mainstay of treatment is increasing fluid and salt. And in many of my patients, you can get away with just that. There are some medications, including beta blockers and Florinef, that can help too if just increasing fluids and salt doesn't help as much as you would like. What we really, really, really try to avoid is putting in ports, putting in central lines, and giving patients IV fluids on a regular basis, because once they get there, that's a very slippery slope. In terms of pulmonary issues, asthma is extremely common in this patient population. There's an increased incidence of spontaneous pneumothorax, and there can be pulmonary complications from scoliosis. Neurodevelopmental issues are often related to the hypotonia that patients can have. We work fairly closely with neurology in terms of patients with bad headaches, and often they help us manage these headaches for our severe patients. This autoimmune neuropathy that I mentioned for adults, we can sometimes see in our pediatric patients, and really this requires the expertise of an experienced pediatric or adult neurologist to help manage. Cognitive delay is not a feature of hypermobile EDS, and as I mentioned earlier, if you see intellectual delay, developmental delay that's severe, that patient has something else. Sleep disturbance is a really, really common thing. In many of my patients, we talk a lot about good sleep hygiene, especially for our teenagers. I use a lot of melatonin. A lot of people don't realize you have to use melatonin about 2 hours before you want bedtime to be in, so they give it right before bedtime. It doesn't work quite so well. Optimizing pain control is really important, so pain isn't keeping patients up. I had mentioned low iron earlier with GI stuff, but low ferritin can make restless sleep be a significant factor. So I do a lot of checking of iron and treating with iron supplements. And sometimes I need to go as far as a formal sleep study to figure out what is going on. So if your sleep is terrible at night, then you have chronic fatigue during the day. And so interventions that we do to help sleep be better often help the chronic fatigue that many patients suffer from and help patients be more functional. Anxiety and depression are common in anybody, no matter what their underlying diagnosis is, that has chronic pain, where they're not functional and they're not able to go to school or go to work or spend time with their friends, which patients could do pre-COVID, not so much anymore. But one of the things that prompted me to learn more about Ehlers-Danlos and to become more knowledgeable about it is that I couldn't help noticing that many of my patients would show up to an emergency room or go to see a specialist and really receive suboptimal care for their symptoms because they were blamed on purely anxiety or depression, and there wasn't enough understanding that there were true underlying medical problems that were going on and needing to be evaluated. So making sure you're understanding what those medical problems are is really important. But then on the other hand, you can't ignore the mental health problems either, because you just need to address both things. And in special care, we have a psychiatrist, we have psychology support, and it's really important to try to have patients be as functional as possible. And then there's chronic pain. This is a major issue in adults and also in pediatric patients as well. We actually have 2 pain doctors in our EDS clinic that help patients, particularly the headache pain, the pain from subluxation. The GI disorders, you can have pain from mast cell disease and eosinophilic disease, and severe constipation can cause discomfort. We're looking more at something called visceroptosis, where if your soft tissue connections inside that are holding your intestines in place are really stretchy, then what happens is you go to stand up and all of your intestines just sink to your pelvis, and that causes pain from stretching. If you have a G-tube or some kind of a cecostomy or something that's holding the intestine up in a certain place, then the pain can be excruciating. So it's making us try to develop a system for how we're studying visceroptosis, what kind of films we need to get. Should we think much harder about putting in tubes in these patients? And sometimes patients can have medical and surgical emergencies that should not be ignored. One of my favorite patients actually had a perforated appendix because her chronic abdominal pain was just kind of being ignored, and they didn't realize she actually had appendicitis. So having a multidisciplinary pain clinic that includes not just physicians but also psychologists is really an important piece of this, of pain management and understanding what are safe medications to use. We really, really, really try to stay away from opioids in the treatment of chronic pain, especially in pediatrics. And physical therapy is the mainstay of intervention for pain. And we have a team of excellent PTs, including those who know how to work with your joints, with your jaw, and with the pelvic floor, that are unbelievably helpful for our patients. So I wanted to have some vignettes to share with you to sort of bring these points home of how these, the most common forms of EDS, which are the classical, the hypermobile, and the vascular forms, can present in pediatric patients. So I'm starting with the classical form. So in very young children, this is a pretty hard diagnosis to make, I would say. And the ones that I have been most sure about are those who have an affected parent or affected siblings. And it makes me think about this. But how young children commonly present: feeding issues, as I mentioned, hypotonia and gross motor delays. Respiratory issues are more common in the younger kids, and can lead to hospitalizations and need for oxygen in the infants and the young children. And the skin, as I mentioned, the easy elasticity and the easy bruising and bleeding is a common presentation for young children with classical EDS. When you move to the school age kids, the feeding issues may be there, but they often are a little bit better than they are in the little ones. Respiratory issues also tend to improve in this age range. Joint problems can become more of an issue because these are kids who are playing soccer, they may be doing gymnastics, and they may be really hurting their joints more because of their activities. And the skin problems in kids with classic EDS can lead to poor wound healing and really lots of scars. So one of my favorite patients who had a collagen 5 mutation, he's a little bit small compared to his siblings, so weight and height just at the 10th. He's on high-cal beverages and drinks whole milk rather than 2% or 1%. There are special shin splints that can help him participate in sports. And then he has actually needed to be treated with Amicar and to be involved with the hematologist here to help for severe bleeding issues. And he does well. He's a smart kid, but he has needed a 504 plan at school to help address his physical activities and keep him safe. In patients with a classic form of EDS who are older, again, nutrition and respiratory issues tend to improve, although asthma can be a big issue. And again, these kids tend to be fine academically, but we often try to have a 504 plan to specifically address their safety in physical education and athletics. And their continued issues with poor wound healing and bleeding can be a problem. So one of my teenage patients who's followed by POEM for bad asthma has a medically inherited EDS. So his diagnosis was pretty clear. I think he went to hematology first and was worked up for a bleeding problem. And then people realized there were other things going on and got to me to have the EDS diagnosis made. And then we will meet when he transitions to high school to talk about bringing these planful things home for his activities in high school so he can be as functional and have as good a quality of life as possible. So the vascular form of EDS is something you just don't ever want to miss, because this is the form of EDS that can have lethal consequences. The three main issues that I worry about are spontaneous blowing out of an arterial vessel, and this is not just the aorta, but it can be any arterial vessel anywhere. I often work with cardiology, and Katie Chetfield here, who's both a geneticist and a cardiologist, has been invaluable in helping to manage my patients with vascular EDS. We do a special MRI of vascular imaging to look at their vessels so that we have a sense of how careful that patient needs to be. And we look at the brain because there can be bleeding in the brain that can be significant. So these are patients who often need to see GI because one of the main problems they can have is severe constipation that can be associated with spontaneous perforation of the bowel. And so we work very hard to keep their constipation management in good control. And failure to thrive is very common in this patient group. They often need extra calories to help them grow. So on the physical exam, when you're seeing these patients, it's very important to document they have this sort of drawn faces with prominent eyes and translucent, almost looking skin with a very prominent venous pattern. And their extremities can be a little bit unusual. They're not as hypermobile in their distal extremities as a kid with hypermobile EDS, but they can have hands that look like a little old lady's hands in a 8-year-old kid. That is called acrogyria, and the skin can be incredibly fragile. So as I was mentioning, my medical management is high-calorie formulas, rigorous constipation management. We restrict certain sports activities because we don't want these kids to be injured. We get a head MRI and they're followed in the stroke clinic preemptively just to make sure we can keep them safe. And many of them are on losartan to try to prevent aortic rupture and are followed closely by cardiology. So I wanted to give you an idea of some of my patients with vascular EDS to sort of give you a clue. So this is a patient I first met when she was in elementary school. She presented, she was sent to me by GI for severe failure to thrive. She'd actually been diagnosed as a young infant with lipodystrophy by an outside geneticist, and had continued to have severe problems with constipation and failure to thrive. Her weight and height were well below the second percentile, and she had the typical facial features and skin findings and these old appearing hands. She had a normal echocardiogram, but her aortopathy panel showed tortuosity of her abdominal aorta, and she had a collagen 3 A1 de novo mutation. By her mid-teens, she has severe scoliosis, and she's undergoing scoliosis repair over the next month or two. My second patient I wanted to share is a girl who had paternally inherited vascular EDS. Her father just dropped dead in the street when he was 27 from a spontaneous rupture of his hepatic artery. And this girl, I followed her for years, but when she was 15, she was admitted to the hospital for severe abdominal pain and a history of constipation, and she spontaneously ruptured her cecum. And then my last patient is a teenager with paternally inherited vascular EDS. Her father had died of an aortic aneurysm. Her older sister, also affected, had died of a ruptured uterus during childbirth. And when this child heard that she had a collagen 3 mutation, she actually became so severely depressed and suicidal she needed a psych admission. So for the rest of my talk, I'm going to be talking about the hypermobile form of EDS. And I think that you all received this wonderful document to give you these criteria to make this diagnosis. You need hypermobility, a positive Beighton scale. You need other systemic symptoms, a positive family history, and you need to exclude other causes to make this diagnosis. And again, we do not know the underlying genes causing this. I wanted to give you an idea with some vignettes about hypermobile EDS and how these patients have presented. The first patient is a 7-year-old with a feeding disorder, a G-tube, multiple food allergies who came to me from the EOE clinic, and motor delays, small kid, hypermobile joints with a Beighton score of 8/9. His mom, who's a nurse, had symptoms of joint hypermobility and had subluxed her shoulders and ankles. And mom had dysautonomia and headaches starting in her teens. So both mom and this child have hypermobile EDS. The second child is a toddler, again sent to me by the EOE clinic with G-tube feeds. He had severe hemorrhage from his G-tube site, had symptoms of mast cell with severe hives. As his GI tract dysmotility progressed, he became dependent on TPN and had subsequent admissions to the PICU for line sepsis. And every time he had sepsis, he developed bleeding and hemorrhage, and he actually died at age 10 due to sepsis complicated by pulmonary hemorrhage, as well as a bleed in his head. His mom just had hypermobile joints, and he has had extensive genetic testing, including exome that has been totally negative. And the third patient I wanted to present is going to be a segue to our research here on campus. So this patient is now in her late 20s. I followed her for many years with hypermobility, chronic pain, poor wound healing, progressive dysmotility leading to first G-tube, then J-tube, and now TPN dependency, followed by an adult rheumatologist with several different autoimmune disorders, and we think mast cell, and has been admitted multiple times to the ICU because of line sepsis and because of the severe poor quality of her life, was in hospice. And because I was worried she was going to die, I enrolled her in the research study so I could try to do some extra studies in her to try to find an etiology of her underlying illness. And so I skin biopsied both this patient and her parents, and the skin has been tested in this research study that I will explain in a moment. She was found to have to be homozygous for mutations in tenascin X, which is a gene not on the dominant EDS panel because it was only reported to be a recessive disorder. Her mom, who's a carrier, has only one tenascin X mutation, has a typical phenotype of hypermobile EDS. Her dad has a totally normal phenotype. And this is something we've seen a lot, that females seem to be more symptomatic than males. So this is just not of my patient, just to show you on the top what wild-type collagen looks like. These nice flowing fibrils, and when you look cross-section, the fibrils all have the same size and caliber. But if you have EDS, and this was reported many years ago, the fibers are disrupted, and on the cross-section, they are all different sizes. And now here is the mother, the father, and my patient with severe disruption of her collagen on her skin electron microscopy and homozygous mutations in tenascin X. Here's another patient of mine who's involved in this research study. She was referred to me by GI because of chronic abdominal pain, constipation, and joint hypermobility. Smart kid, very athletic, but after she got her period, her symptoms have worsened and have led to her being able to be less functional than she had in the past. She has a mother and a sister with similar symptoms. So here is this patient, here is her sister, here is her mom, and here's her normal dad. And so these patients, mom plus my patient and her sister, who's also my patient, have only one mutation in tenascin X, not two, and have a phenotype of hypermobile EDS. So this is a sort of cartoon on the right that shows you tenascin X and how important it is for pulling together collagen and also elastin in the soft tissue. Here's what a normal electron microscopy would be, and here's what it would look like if you have a mutation in tenascin X where the fibers cannot come together in that nice flowing way. So does tenascin X, is this one of the genes causing hypermobile EDS? We suspect it might be. We suspect if you have two mutations, you might be one of the more severe patients with the intestinal failure. that we've seen. And so we have ongoing studies of other patients looking at their tenacin, looking at their EM of their colon with full thickness biopsies, and trying to better understand this. We're also doing elastin staining because tenacin is also responsible for elastin fibers coming together in a nice way. So, and then tenacin can affect elastin, which can then be involved with your vascular system. So is this affecting some of the vascular problems that we're seeing in our patients as well? This is all part of our research study to better understand this. So to summarize that, patients with hypermobile EDS can have a very severe presentation with feeding intolerance, GI dysmotility that can lead to the need for IV nutrition, which can then lead to line sepsis and death, severe constipation that may lead to cecostomy and sometimes even removing the colon, severe abdominal pain, and visceroptosis. So we're making the diagnosis of hypermobile EDS. It's a very complex disorder. We're making it clinically now. There's intense research underway to find some of these genes involved. The symptoms don't just start as an adult, but present during childhood, can worsen in early adolescence, and somehow you get your period and off you go. And seem to be worse in females than males. I suspect a sort of hormonal thing here, but again, we need to understand this better. And it takes a village to care for these patients. We have a multidisciplinary clinic here. It's been in place due to wonderful philanthropic support for a year, and it's made up of pediatrics, genetics, GI, cardiology, neurology, pain team, and PT. And we have over 200 patients now that we've seen in just the past year. And that's the end of my slides. I have a bunch of references for you. And so I think what I'll do is I'll stop sharing so I can then go back to look at the Zoom and see if there are questions I can try to answer in the last time that we have here.
Great presentation, Dr. Elias. Thank you so much. Greatly appreciated. We did actually have a couple of questions come through that I am happy to call out for you.
Okay.
Our very first comes from Willow Sheehan. What is your testing approach for a pediatric patient with multiple nonspecific findings, which can be seen in EDS?
That's a super, super great question, Willow. Thanks for asking it. So, so if you do an EDS panel that has most of the dominant genes on it, it will come back negative often in patients with hypermobile EDS. So often, unless the patient has really abnormal scars and really super stretchy skin, and I think I might find a collagen 5 mutation, or if I'm really, really worried about vascular EDS because of the patient's history and phenotype, I often don't get an EDS panel unless I'm worried about one of those things. What I have been trying to do in those patients in whom I can get insurance to approve it, if they're very, very, very complicated or they have some other severe issues going on, I'll try to get an exome. And on the exome that I've been able to successfully get in patients, I have seen tenacin X mutations. I have seen collagen 5 mutations. Those were the patients that I thought had hypermobile EDS, but actually had the, I have a good half dozen of those that actually have mild classical EDS. I've been getting testing in some of my patients in the OI clinic. I'm the medical director of the OI clinic here. And so if I have a patient with OI who's particularly bendy and has kind of soft and stretchy skin, you know, I often will have looked for collagen 1. And if that comes back negative, I might do an EDS panel. But I think the mainstay is trying to find those genes if I'm really worried about a specific phenotype or looking for exome. The other thing I should mention is that I collaborate very closely with a neurologist, an adult neurologist over at University Hospital, who runs the clinic for people with neuropathies. And he has a research panel to look for neuropathies that has been really helpful. And he's done the biopsies to look for autoimmune neuropathy. And sometimes diagnoses have been made on that panel for which there's no insurance charge. I've had some patients with rare forms of muscular dystrophy, rare forms, collagen 6 mutations, which causes a rare form of a muscular dystrophy. And so sometimes on these other panels, you can pick up patients who actually have EDS. It's hard, though, as you all know, to get insurance to approve to do expensive testing. A lot of my patients have Medicaid, and I encourage them to get Medicaid as a backup secondary insurance, even if they have a private insurance. And if they have Medicaid, I can often get the exome. As part of our EDS center, we were supposed to collaborate with the Colorado Center for Personalized Medicine here on campus, and we were hoping to be able to offer free exome to all the patients enrolled in our clinic, and that kind of got COVID canceled because that lab was sort of conscripted to do COVID testing instead. So I'm hoping maybe in a year or so when COVID kind of settles down, we'll be able to get to that again.
Great. Thank you so much for that, Dr. Elias. Looks like we had one other question come in. How do you transition patients with EDS to adult care?
That's a good one. So we are working very, very hard to build bridges over with adult providers. It's trickier. It's very tricky because there's only one poor geneticist over at University, Matt Taylor. As wonderful as he is, I think he has something like a 3-year waiting list now to see patients with EDS. So to make a diagnosis in adult patients is very difficult. There are some subspecialists over there. I already mentioned Matt Wickland in neurology. We're starting to build a collaboration. We have a meeting coming up with an adult surgeon, Eliza Birnbaum, and her GYN neurology team to help the adult female patients who are having severe intestinal and urogyn problems. There are some adult physical therapists that we work with to help patients to get them PT. There are a couple of cardiologists who are really helpful with the POTS in the adult cardiology population, but it's very hard. They are supposedly recruiting and looking for an adult provider to follow patients with the EOE, and we're very hopeful that that will happen in the next 6 months or so. Because of COVID, there's been a hiring freeze everywhere, so it's hard to find people. But a lot of my adult patients just find it very difficult. I wanted to show something to you all, which is this book. I don't know if you can see it. It's called Disjointed. I read it. It's edited by Deanna Joven. I'm showing you this book not because I'm recommending it. I'm really not recommending it for the medical information in it. But if you have a lot of time on your hands and you want to read something and you have good high blood pressure medicine and you're taking a lot of Tums, you can read it and see what the patients are reading and understanding, because a lot of times adult patients will come to you with sort of understanding about things from reading this book and some other books that are out there in the adult world. for a lot of these problems, there is just not good evidence-based medicine for what's the right thing to do. And so many of these poor patients are so sick and so much pain, just don't have good quality of life or functional status, and they're just desperate for anything. And I think the best thing that we can do is to try to find a really smart internist who is thoughtful and supportive and compassionate, and try to find good providers who are willing to listen and try to help these problems. It's hard though, very hard.
All right. Well, thank you again, Dr. Elias. This is a great presentation. Thank you so much for sharing your expertise. It doesn't look like we have any additional questions come through, so we'll go ahead and wrap up for the day.